when we have a replay of the webinar for those in other parts of the world who can't be with us at this time. So, hello and welcome everyone. Yeah, I'm going to give a real hands wave. It's really good that I think we have about 20 people this afternoon so far joining in this session. It's quite usual that actually people join in the first sort of 10 minutes. We know that connections can be a bit challenging around. So we've got a great agenda this afternoon, and I'm going to ask Cherie if she will share the slide set and we can get formally on. And if we go to the next. So, yep, here is a welcome and a snapshot of our agenda. It's quite a packed agenda. I hope that you will hear from some of our research programs and the subgroups within those and what they've been up to, as well as a number of our working groups, in addition to what we here in the Secretariat want to share with you. Next slide, please. So truly, we know that 2020, it was a disruptive year. The coronavirus pandemic has brought tragedy to millions and has restricted individual lives and reinvented us into almost virtual communicators.
Dios mío, pero no sé cómo silenciar.
But 2020 also has demonstrated the power of science, and in particular, global collaborative science. And for the next slide, please. In GACD, we too, can we go back one? Yes, thank you. We too went virtual with many of our activities, and some of you I know were there to share those events with us. It was a productive year amongst the research network, and we did see a number of jointly produced publications emerge, mostly systematic reviews around lung disease, mental health guidelines, and multimorbidity. The Buddha that signifies our cancer call, the cancer call went ahead. It did go along a delayed pathway, but nevertheless, we anticipate that we will be making cancer awards shortly and announcing those shortly. As many of you are aware, we held our annual scientific meeting and an implementation science school virtually. Finally, on this slide, I just wanted to point out that in addition, we started something new, and that was in marking our 10-year anniversary. We have started to undertake an independent impact evaluation of a decade of GACD, looking at the research that we have undertaken, looking at the research capacity that is ongoing. And I know that many of you may have been invited one way or another to participate in that evaluation, either by completion of a survey or actually by direct interview with the consultants who are undertaking that activity. We anticipate that we'll have a full report that we will be able to share in July. But I just take this opportunity to thank you for all your time and commitment if you have helped us with that undertaking. Can we go to the next slide? So indeed, here in the GACD team, there are a number of new faces. We sadly said goodbye to Gary Parker in the middle of last year, and he has gone to build his career in the user experience world. You might like to know that Faye Pontin has also gone off temporarily on maternity leave. And so I thought it might be quite useful for you as members of our research network to see and link some of the names and faces to the people that are the GACD staff team now. We're all here today, so you can see us and hear from us at various points throughout the session. Apart from perhaps from Cherie, who's turning the slides for me, and Jackie, who's just monitoring activities behind the scenes. In terms of our Alliance funders, I am really delighted that despite all the other calls on their funding commitments, 12 of our funding agencies continue to support us and remain members of the Alliance. And this is a really strong and consistent base that we have had for a couple of years at least now. We do know, however, it has been difficult for some agencies as government economic downturn has cut into budgets and difficult decisions on where their areas of support have needed to be made. However, for the most part, it has to be said, the great majority of agencies have been able to fund and retain their funding for GACD projects and continue to support us in terms of new projects, as I say, the Cancer Call to be announced very shortly. And that will become the newest of the research programs of GACD. Following on that theme, it's a lead up to our next item, which is actually a few words from the funding agencies themselves. This is given to you via Dr. Adam Chapman, who is the chair of our program subcommittee, one of the committees that draws the funding agencies of the Alliance together on a regular basis. And Adam, he is with the National Health Medical Research Council in Australia, and unfortunately it's just a really bad time of day for him. In fact, it's time of morning to something like that. So what he has done is prepared a short video for us so that you feel something of his presence. And so I'll ask Cherie if she can stop the slide share and share Adam's video. It's very short, 5 minutes. Cherie, the sound's not very good on this.
Okay. Okay, sorry about that. Just 1 second.
Hello, my name's Adam Chapman. I'm the chair of the GACD program subcommittee, and welcome to the GACD annual webinar for 2021. I'd just like to give you a few updates as to what's been happening with the program subcommittee over the last few months since I started my term as chair at the beginning of this year. Firstly, it's really pleasing that all of the current GACD members have renewed their GACD membership for the year 2021 to 2022. As you're probably aware, the pandemic has disproportionately affected people with chronic diseases, affected by chronic disease, and particularly those living in conditions of vulnerability as well. So this really does highlight the critical nature of the work that the Global Alliance for Chronic Diseases undertakes. It's also really pleasing that interest in the GACD has not diminished among the research community, particularly as the pandemic has really affected things right across the globe in the last 12 to 18 months. And that there's still ongoing work through our working groups, and various research programs are still looking at how they can best identify the learnings across all the projects and various geographic locations, because as you will be aware, GACD, with its global reach, has projects in a wide range of places. So you should all really be looking forward to hearing the updates today from several of the working groups that have been undertaking this work. The other thing that's been really pleasing this year has been the launch of the Implementation Science eHub, which you can find links to on the GACD website. This is a really important resource because it really highlights the way that implementation science works, which is important because it's still a relatively young and growing approach to these kind of research on chronic disease, and getting the implementations and interventions that can really have some wide-ranging impact. So I'd really urge you all to, if you haven't already, to get on and have a look at that, because that should really help with fostering a bit of research capability building and getting people much more familiar with how implementation science works and the benefits that this approach can bring. A quick update now on some of the funding actions we've been doing. You'll be aware that in 2019, GACD launched a cancer prevention call. This, of course, was impacted by the pandemic, and there were a number of delays that happened with the timelines, but all participating agencies are now getting very close to making the outcomes of that round known, and so you can look forward to hearing some of those announcements from the participating agencies over the next several months. The program subcommittee is also very busy developing materials for the next funding call, which is going to focus on common non-communicable disease risk factor prevention in identified life stages, particularly in youth and adolescents. Different agencies may have slightly different takes on this, but that's going to be the main emphasis, will be in adolescents and youth. The program subcommittee is now working to develop the call text a bit further with a view to launching that around the end of the year, but final timings are still to be decided with the ongoing impacts of the pandemic on various groups, operations, still to be still affecting some decision making. And finally, just I'm sure that these two sessions are going to be really interesting and provide you with a lot more insight into what's been going on around the GACD. Of course, you can also should also be looking out for opportunities that are on offer by the various member agencies who participate in GACD, because there's, as you know, they're all national level funders, and so they have a range of fellowships and sometimes implementation science related projects, as well as their regular main grant programs, which can offer various opportunities for you all. So just in closing, I'd like to welcome you once again to the GACD annual seminar. I trust it will be very informative, and I wish you all the best, and please enjoy the presentations that are coming. Thanks.
Thanks, Cherie. If you can get us back to the slide set, and then we will move quickly to the next item on the agenda, which is an update from Alyssa, our program manager, and Izzy, our research capacity strengthening manager, who are both going to share some of the ongoing and future activities that we at the staff team are busy on. So over to you, Izzy and Alyssa.
Thank you, Morven. So as Morven said, I'm the research capacity manager. I think I've probably been in contact with many of you over the last few months. I started just in November at the time of the Implementation Science School. So just as a reminder, I think people talk about the research network in many different ways, but when we say research network, we mean everyone who's working on a GACD project, and that includes projects that have completed. And all of these projects are grouped into research programs, and at present we have 5, and they're grouped by the disease areas. And we're looking forward to welcoming our 6th in the coming months on cancer prevention. So I'm just going to take a few minutes to update you on some of the activities in the research network over the last year. Next, please. So first up is a thank you around a database that we're building. This is all very much behind the scenes stuff, but everyone's been very patient and polite with lots of emails that have been going out to you. So we have consolidated and updated our research network database, and it's all up to date and accurate now. And it's a huge thanks to you guys for completing the online forms, and a huge thank to Cherie, who's not on screen at the moment, but she took on a substantial load of the work getting that sorted. If you checked the box to receive newsletters, you may have noticed the first one came out a few weeks ago with updates from across the network. And these newsletters will be coming out quarterly going forward. So if you do have any news updates or announcements you'd like shared with the whole research network, please get in touch with me and we can put something together. Next, please. So this just moves on to the working group updates. For those who aren't sure, the GACD working groups tackle key issues within the field of implementation science and NCDs. And people from across the different research programs come together to collaborate, exchange learning, find solutions, and share knowledge. And we currently have 10 active working groups. You'll hear a more detailed update from the NCD multi-morbidity group later in the webinar, but I'm just going to give you a brief overview of what's been happening in a few of the others. And as Morvin said, just to note, as you are all very aware, this year has been an enormous challenge for everyone. So many working groups have understandably taken a pause or slowed down their work at this time. So the concepts and context working group, they aim to describe the methods used to characterize and account for context incorporated in studies at various levels, and also identifying common themes across selected projects for case studies. And they've so far published an article or a manuscript on the context component and working on the concepts part now. We've also got a NCD research in humanitarian crises working group. It's a little different to the others as it's a collaboration with people and organisations external to GACD, but they're currently developing a survey to better understand how NCD care in those humanitarian settings has been affected by the pandemic. We have an Indigenous populations working group, and they've aimed to develop a researcher's statement to address the gaps in the field of implementation science in relation to Indigenous population groups. They are close to finalising their statement, and once they've done that, they will progress with a literature review and another paper evaluating GACD projects with an Indigenous population. So there's also the systems approach to upscaling working group. They had their most recent meeting a couple of months ago, and they're hoping to apply a systems lens to the GACD scale-up research program projects. So identifying challenges, enablers, barriers. A protocol paper has been drafted and it's currently being reviewed and reiterated before being submitted to a journal. There's also some discussions within that working group about a subgroup to explore and characterize the use of process evaluations and economic evaluations across scale-up studies. It's at a very early stage, but there seems to be a lot of appetite to examine it further. There's ongoing work within the diabetes research program to produce a set of guidelines for process evaluation in this disease area. And that's something that's already been completed for hypertension. But the diabetes specific survey was distributed last year, and some findings initially were presented at the annual scientific meeting. And since then, a manuscript has been under development. And then lastly, we have a number of data standardization working groups. So they're not the most exciting title, but a really important area of work. And they're developing consensus measures across different disease areas for implementation science. And they're hoping to be collated into a single GACD data dictionary. So moving on to capacity development, next please. Many of you will know about our implementation science schools. They've been taking place in Brazil and Thailand in previous years. Last year was obviously all through Zoom. And this was done with great success. So huge commendations to the faculty and the facilitators who made that program super interactive and engaging despite the change in format. So the program that they developed had around 8 hours of pre-recorded content, but then 38 hours of live interactive plenary and small group content. And that was all facilitated through video conference facilities. So it was a competitive application process. We had 140-ish people apply or start the application, and that was whittled down to 47 trainees from 23 countries. There was an evaluation of that school, and it seemed to go down pretty well. 95% of the trainees would recommend it, and over 90% said that they were likely or very likely to apply the knowledge that they gained through the school. And obviously a huge component of the success there was the eHub, and we'll get into some more detail on that, but it's an exciting development which I'm sure you'll all be impressed by when you have a look at it. And lastly, I mentioned earlier about updating our research network database, and this is extended to reaching out to alumni from previous implementation science schools and workshops who are not actively involved in the GACD project. And we're thrilled that well over 100 people responded to that, and we're developing a plan for engaging with this group more actively over the coming year. And that was very much a whistle-stop tour, and for this last part, I'll hand over to my colleague, Alyssa. So next, please.
Thanks so much, Izzy. Hi, everyone. I'm just going to give a short update about the digital health workshop that we're planning for early July this year. So the focus of this workshop is going to be on the barriers and enablers of conducting digital health research focused on NCDs in LMICs. So we'll be looking at examples from within the research network, folks who are already conducting digital health activities, as well as invite a few external speakers who are experts in this area to share their experiences working with digital tools. And we know that a lot of you have had to adapt to the COVID pandemic by going virtual when maybe you hadn't been planning to initially. Another reason that we're hosting this workshop is that our future calls, which I'll go into a little bit more detail about in a moment, will emphasize digital health interventions. So they won't exclusively require that applicants focus in this area, but they will be encouraged. Sheree, next slide, please. Thank you. So I know you've heard a little bit about the future calls already from Adam, our PESC chair, but just to provide a little bit more detail, we have selected the call topics for the next 3 funding calls. 21 call, as Adam mentioned, will hopefully launch at the end of this year, though potentially early next year, just due to the ongoing challenges of the pandemic. 2021 call will focus on vulnerable life stages and NCD prevention interventions in those life stages, with a particular focus on youth, though, as Adam mentioned, some agencies are looking a little bit more broadly than that. The 2022 call will be focusing on interventions in urban environments, again, with a focus on prevention. And 23 call will be a little bit different, and that'll be focused on multimorbidity management, so moving away from prevention. So the major developments with these calls is that we are moving, as you can see, to an annual call cycle. Previously, we launched calls about every 2 years, a little bit less frequently than that. So it's very exciting that our funding agencies are committing to a more frequent offering. And previously, most of our calls have focused just on one particular disease issue, like mental health or lung disease. And now we're focusing more on these common risk factors across different NCDs, as well as as well as multimorbidity management. I will share in the chat box momentarily a link where you can sign up to receive more updates about these calls, including things like the timelines and deadlines, and more information about the call text and expectations around what we'll be looking for. At this point, I'll hand it back to Morgan. Thank you, everybody.
Great, thanks, Alyssa and Izzy. I just thought it might be helpful to ask the floor, those participants, if there are any questions or comments, you can raise your electronic hand, open your window and ask the question, or just pop it in the chat and we'll try to get back to you. I see that there is already a question in the chat around when we think the 2021 call will be launched. We are hoping that it may be launched in November 2021 by at least a group of the funding agencies. However, it may be pushed into very early in 2022. So I hope that helps with that question. But happy to take any other questions or comments that you might have at the moment. I know, don't want it all to be too one-way traffic. It is a little difficult, I know, though, to have a very open discussion in Zoom. I don't see any electronic hands running up and down my participant screen. If you have any questions, pop them in the chat and we'll take the opportunity to move to the next item, which is actually from a group of a team who are working within the mental health research projects. And I'd like to welcome Jill Murphy. Hi, Jill, I see you've opened your window now. And also Kenneth Fung, who is also there. I don't quite see you on my radar there, but I know that you're there. How do you want to do it, Jill? Would you like to share your own slides, or do you want us to share the slide set that you sent?
It looks to me like Kenneth has shared his screen. I'm not sure if everyone can see that.
Yes.
He's made a couple updates to the slides since the last version. So if you're okay with it, we'll work from Kenneth's slides.
That's perfect. And hopefully I didn't do a very good introduction there, but I'll leave it to you to introduce what your group has been doing. Thanks very much, Jill and Kenneth.
Thanks. Can everyone see the shared screen, right? So perfect.
Yeah.
Yes.
So thank you very much for this opportunity to present a little bit of our work. So Joe and I will be leading the presentation, but this is on behalf of the GACD Mental Health Program Coronavirus Impacts Group, or MH Pronto Working Group. What a beautiful acronym. And really this is the work of everyone in our team. Thanks to Bern, Tellini, Mariana, Shihiros, Rebecca, and Lena, and a special shout out to Izzy for really patient with us and helping us, sending us really courteous emails, but persistent in helping us get this work done. And the GACD Secretariat. So just to give you a brief overview about what this group is about and what this presentation is about, really our objective is to help us understand and to reflect on the impact of COVID-19 pandemic on this GACD projects. As you know, the pandemic has affected everyone on the planet, and so we certainly want to take this opportunity to understand what the research progress is and the capacity, how the pandemic has affected each of our projects, so that it's an opportunity to understand how something like a pandemic can affect our projects, and of course identify areas that we can help each other on, because GACD is about global collaboration, and certainly to get out of the pandemic requires that. And so with that, we are particularly interested in adaptation and innovation that arises in addition to the challenges and the delays that is expected with the pandemic, as we've heard, because we know that this is also a chance for us to share adaptation and innovation that can help all our projects and really help our target end users, of course. And technology use is another thing that we want to focus on, because we know that one of the things that can help us during the context of the pandemic is technology. And of course, this has vast implications, given that our projects often are in developing countries with differences in technology use and development. So we are interested in that. And of course, underlying it all is equity, because GACD is about achieving and promoting global equity. So we want to understand, particularly as we are looking at these adaptation and technology use, how it impacts on different groups and in terms of equity, and what are the groups that may be marginalized. So with that, we have devised as a first step a survey of the existing projects. And so what we'll share with you is a preliminary data. It's quite preliminary because we literally got our data like last week. So we had a few days to pull together. So it's rough around the edges, if you would bear with us, but we're excited and we want to share with you just the rough data we've got. We've got 32 responses representing 21 projects, and that's a 58% response rate, which I understand is quite respectable in the history of GACD project-wide research. And just to give you a snapshot of some of the target country characteristics that the researchers who were responding with described in terms of income level, the highest group is in the middle income countries, but also with the low and high income countries respectively, you can see there. So about 50% of the projects do involve middle income countries, about 30% for the low income countries. In terms of urbanization, again, around 42% is in urban setting, but the rest is in semi-urban or rural setting, which of course may have implications when we talk about technology use. So in terms of target populations that the GACD projects are serving, about 28% is on general adult population, and 26% is on those with mental illness or substance use issues. So those are the predominant group. And then you can see the rest includes specific target groups like seniors or women, caregivers, or family members, men. So those are the more specific groups. But certainly that would be almost 50% is more on the general adult or those with pre-existing mental health conditions. And in terms of target conditions, about 32%, a third is on common mental disorder like anxiety and depression. And then 1 in 5 is on the more severe mental disorder, including psychosis and bipolar disorder. And then you can see the balance of the rest includes mental health promotion, mental health stigma, early intervention, substance use, suicide, cognitive disorder, and other comorbidities, with about 2% on specifically childhood and developmental disorders like ADHD. So again, the most is on the common mental disorder and the severe mental disorder, and with mental health promotion coming in at third. So those are the target conditions. So this is just a brief snapshot of the characteristics of the respondents, the GACD researchers who responded to the survey. And then this is a snapshot of what the researchers have shared in terms of the COVID pandemic impact on the research project. So on the left-hand side, you can see we have described different components of the research studies. So the first is timelines and milestones, how the pandemic has affected, how timely things are, and do they need to delay the project. The second is on preparation, that includes the contextual analysis or training or the prep work. And then the third is the target. Do they need to modify inclusion and exclusion criteria because some groups become unreachable in the pandemic? And the next is sample size. Given the pandemic, do the target size and recruitment size are impacted? And the next is the level of intervention and data collection. And then the last two is partnerships and collaborations, because this is about partnerships on the ground as well and how that's impacted. And of course, KTE, knowledge transfer and exchange. And you can see in the graphic there, blue on the left-hand side is the positive. So there are a few projects that talked about that their projects in specific categories, there was a positive impact. Of course, you can see a lot of them have a negative impact. Those are the color bars. That's non-neutral. And if you focus on the darker color bars, that is the substantially negative and severely negative, you can see the outline on the right-hand side. That timeline on milestones is one of the highest categories with, I would say, over 60%, close to 70% of the projects have been impacted in terms of timelines and milestones. And then you can see intervention and data collection are also quite impacted, over 50%, over half of the projects are at least substantially impacted to severely impacted by the pandemic. And you can see that the red is severely negatively impacted. You can see the sample size in 4 of the projects, it's been severely impacted on the sample size. So this just gives a snapshot across the projects on how some of the different areas have been impacted. Of course, this is just very preliminary analysis. And I will share with you another preliminary analysis that we have done, that our group has done, which is looking at the difference between those who are serving low-income countries versus the non-low-income countries. Again, this is rough data looking at those same categories. You can see that the low-income countries by numbers in some categories are more and some categories less. What we did is we converted that into a scale where if it's positive, it's actually -1, if it's neutral, 0, and then 1, 2, 3, to give a score of the degree of negative impact to come up with an average score. And you can see in that roughly, actually, in both are similarly impacted in a negative direction. It's above 0. But in terms of significant difference, there's not a whole lot of difference between the two in just this kind of rough look, except for KTE. Interestingly, KTE, if we presume a one-tail test, presuming that it's harder in the low-income countries, then it's significantly more impacted and in the low-income countries. So the bottom line is that all countries are similarly affected in a negative way. It's above 0. And then perhaps there might be a signal for KTE. And then if we look at it another way, which is substantially or severely negative, those harder, darker categories, and you can look at it categorically, and you can see why KTE, there's a signal, because basically half of the projects that serve the low-income countries reported severely or substantially affected in terms of KTE and even collaboration. So looking at substantial negative. So this may have an indication, perhaps low-income countries already are resource, of course, poor. And so even the partners on the ground may need to redivert their investments in time for collaboration and for KTE efforts. Perhaps this is one of the difference that is driving. So even though all projects are involved, you can see the partnerships that's involved in collaboration and dissemination KTE can be even more severely impacted. So this is, of course, very preliminary, but this is what we have so far. And of course, I'll now turn to Jill, who would also take us through the use of REAIM framework.
Thanks very much, Kenneth. Can you go to the next slide, please? Thanks. And so in the survey, we also asked participants to map the COVID-19 impacts on their projects onto the REAIM implementation framework. And we did this to capture preliminary implementation impact of the COVID-19 pandemic on the research studies, as well as to align with the work of the data standardization working group that's led by Melissa Pearson and Paula Malik. And is doing work mapping data collection and metrics onto the REAIM framework. So we wanted to be consistent there. So as you'll see, so projects could select more than one impact. The most significantly impacted were reach, or so ability to reach the target population, and implementation, which refers to the interventions being delivered as intended. So this includes things like timelines, cost, fidelity, and things like that. 28% indicated that the pandemic had impacted adoption. So this refers to uptake by key stakeholders, with 22% noting the impact on effectiveness or sort of target outcomes of the research, and then 16% on maintenance or sort of long-term uptake and sustainability. And this lower impact on maintenance may indicate sort of the stage that people are at in the projects as well. So not really being at the stage to think about sustainability so far. But of course, the most predominantly impacted are reach and implementation. So next slide, please. So we included some qualitative open field questions to sort of assess different aspects of the impact on each item on the REAIM framework. And in the interest of time, we're just going to highlight some of the impacts on the two most impacted. And so these responses referred to the barriers in reaching the target population as a result of the COVID-19 pandemic. And so we've also de-identified these, removing any reference to specific countries or conditions for the sake of anonymity. And so you'll see a few key themes here. So one project said lockdown and quarantine measures made gatherings and reaching the target population almost impossible. So the restrictions related to the COVID-19 pandemic changed the ability to meet in person and to gather and to actually access the target population. There's also another study that says a lack of engagement and interest due to other COVID-19 impacts has led to a decline in interest and subsequent recruitment into the study. And so, so this speaks to a shift in focus and priorities in target communities and countries that's impacted the ability to reach the population. And then finally, here we see the impact of technology, which we discuss a lot later on. We can only reach people who have access to and the ability to use technology like tablets or iPads through which we are delivering our intervention. This has inevitably resulted in those with more moderate target condition, the less educated and poorer communities having no access. And so we start to see an equity impact based on the new dependence on technology as a result of the pandemic. Next slide, please. And so in terms of pandemic-related challenges that affected the implementation of the mental health research studies, again, we see the impact on priority among key stakeholder groups. So this group said policymakers' priority is COVID, which makes engagement and dissemination to embed the intervention in practice difficult. And so this is quite a key theme around this sort of shift in priority away from issues other than COVID-19 response. Another group said our intervention relies on small face-to-face groups of vulnerable populations in 3 severely hit countries. This means that we have not been able to implement as intended with no expectations of being able to in the near future. So in this case, a couple of things: reaching vulnerable populations in very hard hit countries has meant that there's a complete inability to access the population and therefore implement the intervention. And finally, we have one study that says the actual program has been carrying on despite the pandemic related factors, such as clinic closures or lockdown measures, just in a different format. The implementation of our final study aim, testing strategies to improve the program implementation, was derailed. And instead we were focusing on what the different format of delivering the program entails and how it affects program delivery. So in this case, we see a need to shift the study focus or goals to respond to the challenges that are posed by pandemic-related restrictions. Next slide, please. Wonderful. And so as Kenneth mentioned at the beginning, we wanted to capture a lot of the adaptations and innovations that mental health projects have put in place as a result of the pandemic, recognizing that though the pandemic has posed significant challenges across the board in terms of research impact, many studies have been very innovative in adapting to the new conditions. So we wanted to capture some of that through this survey. So broadly and unsurprisingly, we see a lot of adaptation to the use of technology, including both digital technology and telephones, for everything ranging from the way interventions are delivered, so shifting from face-to-face to either digital or phone-based models, for delivering training using digital technology, to collecting data either over the phone or via digital technology, and also, of course, team communications, as we're doing now on this webinar. A lot of projects have shifted to using technology to support team communications, both across countries and within countries and communities. Other adaptations include providing additional support for project staff and communities in countries. And these include examples like study teams providing devices like tablets where possible to enable access to training, interventions, screening, data collection. Providing training to communities and local staff on using digital technologies in order to make the shift to that modality, as well as some teams that are providing PPE for their project staff to improve safety and ensure that they're safe when they're delivering interventions or collecting data. Next slide, please. And so we've already talked a lot about the use of technology. Obviously, there's been a massive shift to using technology in every aspect of life, including in research. So we wanted to capture some of these adaptations through the survey. So we first asked study respondents what types of new adaptations or significant new adaptations they'd made to the use of technology in the context of the COVID-19 pandemic. So you can see almost half of them have shifted to online project team meetings. I'm sure many people are familiar with shifting to that means of communication within their project teams. 34% indicated that they had shifted or enhanced both to the use of technology for both providing staff training and for doing data collection, so about equal there. And then 32% have shifted or enhanced the use of technology to actually deliver their intervention. And so we only had 6% of respondents that said this wasn't applicable. So we see a large shift towards the use of technology in sort of every aspect of the project delivery and intervention. We also asked people to identify the key challenges that they've faced in making this shift to technology, recognizing that especially across different contexts and different study populations, that the use of technology may pose several challenges. So we have almost equal responses on the first three. 30% noted that there was limited access to technology by end users, which posed a challenge. So having access to things like computers, mobile phones, internet, stable internet connection, things like that. 28% noted that it was difficult to engage their target populations or end users by using technology. So this could be anything related to digital literacy, access to technological devices, or willingness or acceptability of using technology in the different types of interventions. And again, 28% indicated that they'd faced a challenge in adapting their intervention or training to be delivered remotely. So having to make that pivot towards kind of reframing and redesigning their intended intervention or training program to be delivered remotely. And 20% indicated that poor system-wide connectivity in the study regions was a challenge. And this, of course, would be expected more in sort of rural, remote, or low and middle income country contexts. Next slide, please. So as Kenneth mentioned, underlying all the work that we do and is really concerns about improving equity in mental health among populations. And so we wanted to capture some of those equity considerations recognizing that the pandemic has not equally hit all populations, and that people that had pre-existing vulnerabilities or regions that had lower resources are likely to be more affected. And so, as Kenneth mentioned, this is very, very preliminary. We did just get close the survey about a week ago, so we've turned this around quickly. So we do intend to do further analysis that disaggregates the results by looking at country type, setting, target population, and target condition to get more in depth into these sort of equity issues around the impact of COVID-19. But in the survey, we included throughout questions that spoke to things like the social determinants of health, specific vulnerable populations, and target differences between countries. And so we have heard from survey respondents that there has unsurprisingly been a substantial impact on their target populations, especially in low and middle income countries. Examples include increases in poverty, increases in domestic violence, substantial interruptions in access to existing mental health care or other social support and psychosocial services. So we are seeing a substantial impact across populations. Also, barriers to technology use in some countries pose an equity concern. So we already talked about some of the challenges around connectivity, device access, things like that. But also some populations, such as seniors, people experiencing dementia, may have additional barriers to accessing and using technology in the context of COVID-19. But we also heard a lot of positive responses specifically related to equity and the increased use of technology, which was encouraging. So some studies noted that because of the need to shift to digital technologies, it's led to increased capacity building amongst their study populations, in communities, among local staff, in terms of how to use technology in all manners of anything ranging from screening to online meetings to data collection. So it's led to a capacity building opportunity. It's also led to expanded participation in things like study team meetings, where not everybody would have been able to participate in person, for example. It's kind of opened things up to allow for more engagement by more people in some study teams. Also, virtual interventions have been identified in some studies as cost-effective, being suitable for scale up, and essentially having the potential to expand the reach of the intervention more so than in-person delivery and consultation would have. So we're really encouraged to see these positive impacts as well, especially related to equity and increased capacity and reach among populations. Next slide, please. So in terms of next steps, as we both mentioned, this is preliminary results that we're presenting today. So we do plan to do further analysis of the data, including more disaggregation and more tests of association. Kenneth presented the impact on several aspects of the research process, but we plan to do more in-depth analysis on that. We'd also like to follow up, and those of you who have completed the survey, we thank you very much. And you will have seen that we intend to conduct a couple of focus groups to sort of have more in-depth conversations about these issues around the use of technology, adaptations and innovations, and the impact on equity in the context where you're working. And so some of you let us know via the survey that you're interested. We really appreciate that. And if others that are participating today are interested, please, contact Izzy and the GACD Secretariat, and they can let us know, and we'll be sending around concrete details about, I was going to say when and where, but obviously the where will be Zoom. But the when we can share shortly, and we intend to have them around mid-June. So just let us know. And the ultimate goal of this is really to capture across the portfolio of the mental health projects the impact of the COVID-19 pandemic on these different aspects of research and the context where research takes place. So we will be disseminating it via the GACD network and intend to generate a publication from this work as well. So I'd like to thank you very much for your attention. Thanks again very much to Izzy and the GACD Secretariat. And Kenneth mentioned the beautiful acronym, which I have to give credit to Izzy for, because that was her creation. And we're happy to welcome any questions or discussion.
Thanks very much, Jill and Kenneth. It was really interesting study. Clearly, it's relatively early days. You may not have answers to every question. And we are running short of time, but I know there are representatives from some of the mental health projects here today, if they wanted to reflect or comment or have any questions. Selini, I think you are here also as chair or co-chair of the mental health research program. Really good that you've joined us. It's probably rather late night where you are at this time. So thanks so much for that. I see there are some comments going into the chat. Does anyone want to raise their hand and have a question or a comment at this point? I think Melissa? Did I see
Yeah.
box? Hi, Melissa. Hi.
Hi. I was just interested also too if you've, I know, obviously early days, but if you've had an opportunity to think about whether the impacts are differential depending on how severe the outbreak was, or lockdown restrictions, or various other sort of maybe policy measures that may have been implemented. And I know that's a sort of moving picture, but it may help to understand, some of the positive and negative comments.
Really good point. Thanks, Melissa.
Yeah, thanks, Melissa. Feel free to jump in, Kenneth. We haven't really captured data on specific. I think it might be a bit tricky because we don't exactly know which country and context everyone's responding from, but I think it would be a very important addition to the analysis to kind of explore the diversity of experiences around COVID-19 severity and also response, like you mentioned. So that's something that we could certainly discuss, including.
Yeah, I think you point out something that's very important. I think number one is it is a moving target, right? Everywhere, the conditions are always changing and policies are always changing. So even any cross-sectional survey, it's going to be difficult to capture that. We do hope that the focus group can fill in some of the gaps. We also have, even within the survey, asked people to share if they're aware of local policies, like you said, that would change things. We've heard from lockdown measures. So there was someone who did share, for example, in Ukraine, like looking specifically in a very specific country and context and substance use, and how it all, for example, substance users who are dependent on clinics for methadone treatment, and so how that's impacted with the lockdown. So as you said, the consideration of the condition plus the local policies, what is closed, what's not closed, and then what's the adaptation? What was the government policy of and allowing people to take methadone home rather than must be instituted clinics? So there was a whole complete report that was done. So we're hoping to gather some of these resources so that we can get a snapshot of what are some of the best practices. So you're absolutely right. We want to get more richness, and hopefully the focus group can also help in addition to analyzing the survey data.
Yeah, and just to add, if there are any groups that have prepared similar reports or have additional input around innovations or work that they've done in depth regarding the impact of COVID in their own study countries or teams, we'd be grateful if you'd share them. So.
Thanks very much. I think there's a lot of food for thought, a lot that's still to be explored in the mental health context in terms of the impact of COVID, but also in other disease areas as well. And we know that some of the other research programs are also doing a similar survey amongst their particular projects. I think at this stage, please do continue to put any comments, questions. They might only just be coming to your mind now. Pop them in the chat. We can share the chat with people thereafter. But I'd like to move us along because I know that we've got a couple of other presentations that we'd really like to hear from. And queuing up, I think we're now turning to the multi-morbidity working group. And first up, we have Can Bunke, who's going to talk about a new exercise, a new undertaking that he's about to go forward with, and he will share with us today. So Can, are you sharing your own slides, your own screen?
Yes, I am.
Perfect.
Thank you for having me.
And
I hope.
I see
Yes.
it. Yes.
Okay, good.
Great.
Very relieving.
Yes, go ahead, please. Thanks, Can.
Thank you for having me. Yeah, I'm Can Bunke from the University of Dundee, and I'll be just giving a brief input on a Delphi survey within a larger project that we are currently commencing and that the GACD is very helpfully supporting at a crucial stage. And I'm speaking here for the Impact Collaborative, which is a global health research group hosted at the University of York. But you see, there's loads of partners involved, including the GACD. And our original goals for this were to improve health and reduce deaths associated with diabetes, heart and lung disease in people living with severe mental illnesses, and to reduce depression and anxiety in people living with chronic physical health conditions. And I'm just going to talk about stuff that has taken us over the last 5 years into a slightly or additional directions, let's say. This is NIHR funded work, so I need to point out that I'm expressing my own views, maybe not even my collaborators' views here, but definitely not necessarily those of the NIHR or the UK Department of Health and Social Care. So what I probably don't need to stress in this area is that the multimorbidity is now quite a broad concept and basically includes all types of diseases and conditions that are characterized by occurring together and over a longer period. And I think for us, it was quite a development in the project since we started very much from the mental health and physical non-communicable diseases type of area. That was the main focus. The core of the original research group was really interested in severe mental illnesses and the reduced life expectancy in people suffering and living with these severe mental illnesses. But over the past half a decade, really, we have really started to embrace the full definition of multimorbidity, including infectious diseases, which feature in parts of our research program now from the past few years. And some of the central problems that we are interested in for low and middle income countries, and certainly not only core problems in this for low and middle income countries are, well, obviously healthcare systems are fragmented. We're in this population, we observe far more frequent health visitors and consultations, longer hospital stays, increased healthcare costs, more out-of-pocket expenses, and so on and so on. And those are all problems that are really important. But one thing we are focusing on this particular project is the question, how does research actually support this, and what are challenges in research and practice-based evidence generating this? Because most of the research, and in particular randomized clinical trials, often adopt a very single disease, single condition focus instead of trying to develop evidence that can also or is tested across a range of conditions and combinations of conditions. And that speaks directly to the problem that a key aspect of any of this research is how to define what the outcomes are. So in which types of things intervention should be effective. Yeah, what should it change? And outcomes therefore need to be appropriate and comparable, appropriate for the particular problem and disease at hand, and comparable at least within that research area, so that we can build evidence addressing particular condition or combination of conditions. But they also need to be relevant to the key stakeholders, be it patients, carers, health system managers, researchers in the end as well. So that is actually the evidence that generated is useful for making decisions about healthcare and what type of healthcare to offer. And in that area, the concept of core outcome sets or framework of core outcome sets has been developed to address this challenge and to build a consensus process that helps develop a framework to generate such evidence. And core outcome sets are agreed standardized set of outcomes. And these agreed standardized set outcomes are condition or population or combination of population specific, and they should be measured as a minimum in any research and any other even naturalistic studies, health systems evaluations or so, as a minimum standard, so that they are available for anyone who works in that particular area. And there's a process that I'm focusing on in the next few slides very briefly, but to give you first some examples, as we are obviously not the first ones trying to address this problem. Core outcome set has been developed for multimorbidity research by Susan Smith and collaborators. And to give examples of what these outcomes look like, well, it's health-related quality of life, mental health outcomes, and mortality, which were identified as the key top-ranked outcomes across a number of stakeholders that should be measured in all of these trials. But there was also a list of other outcomes, just briefly mentioning patient-reported impacts, physical activity and functioning, consultation-related, health systems-related, but they were far further down in the priority list than those first three. So that is basically what we are trying to develop as well, and to see how this looks, particularly in the context of low and middle income countries. What connects us to this meeting and the GACD is the work of the multimorbidity group, where there was a focus on how to address these multimorbidity challenges, to build on successful global health research and build global health outcomes really nicely. And they identify those 8 outcomes that are on the right-hand side. And they were guided by what seems to be useful and favorably discussed in the literature and in clinical experiences across the group members. So we have one existing outcome set that did not specifically address low and middle income countries. That's the first one that I showed. And the second one here was a result of a non-systematic process. And we are trying to address the gap between those two. And what we do is trying to develop a core outcome set for prevention and treatment studies, particularly in the context of low and middle income countries. And based on our multimorbidity definition, we're trying at the moment to finish the identification of relevant outcomes from systematic reviews based on about 17,000 screened papers and 100 really good studies that were included in our final review, and qualitative research across 10 sites in low and middle income countries that were helpful enough to generate these. And we have half the interviews finished and coded up. And the next stage is the multi-round Delphi survey, or 2-round in our case, which we're trying to pull all of these pieces of evidence together and to produce the ranking. And for that, we will utilize a Delphi study. And just briefly, what is a Delphi study? Well, it was developed in the 1950s at RAND, where it's usually credited. And what the general structure is, you have some definition of experts. They answer questions that are posed to them anonymously, or at least without knowing each other's responses. The results are aggregated. The questions and the previous responses in general as an aggregate are posed back to them, and they can then deliberate individually and pose new responses. And this is reiterated until for example, an agreement is found, or in our case, we have consensus building, so convergence of opinions. In these studies, it's limited often to 2 rounds where we are targeting these stakeholder groups, from people living with these multimorbidities down to researchers across, in this, the Delphi will address low and middle income countries in particular again. And researchers is the only category that's more widely opened. So also high income country researchers who work mainly in low and middle income countries. We're trying to target about 80 participants. Firstly, ranking the outcomes that we find from the previous parts of the study and suggesting potentially outcomes. And in the second round, providing us with a new assessment given the evidence that has been collated before, what other people in the Delphi round found useful. And that is then taken forward to consensus meetings, which will obviously happen online and virtually, but that makes it potentially even easier to include a far broader and more diverse group of participants in these, which then should result in a core outcome set potentially similar to the ones that are existing, but they take in particular into account the low and middle income country settings view on how prevention studies and treatment studies should be evaluated and what the core components of this are. So I think I'm just in my 10 minutes here. So this is our webpage. There's all kinds of other projects that we are undertaking at the moment. We are Cosmos, so if you are looking for more details on this, please have a look there, and thanks a lot for having me.
Thanks very much, Jan. I have to say that we do feel that looking at multimorbidity outcomes is certainly something that potentially will be extremely useful in our future, particularly as GACD has already sort of the idea that its third future call will be on multimorbidity management. And therefore, actually, it's really quite pertinent to that. Again, we're, as ever, it's always the case, we run short of time. If anyone has a burning question, please do pop it into the chat. I'm sure Jan will in future be contacting many of us around engaging with the research community to actually inform his survey. And I think that's where actually the wealth of the network can come and help actually cascade that out to draw in the best and broadest necessary range of expertise and experience to help you with your Delphi process.
That would be really fantastic, yeah.
So thanks very much, Jan.
Yeah, thank you for having us.
Is any questions popped up immediately? I don't see anyone with raised hand, so I'd really like at this stage to, rattle things along, push along. And I'm delighted that we have Natalie Leon, who's actually going to talk to us today about another piece of work that the multimorbidity group has been undertaking, and that's the production of a policy briefing. So Natalie, can I hand over to you? And I think we have your slides that we can take you through. So if you just work with Cherie, ask for the next slide when you would like it.
Okay.
Thank you very much, Natalie.
Thank you very much. Cherie, can I have the first slide? That's it? Okay, we can. So basically, what I'm doing is I'm just sort of briefing you on a brief that one subgroup of the multimorbidity GACD groups work on. And just to put that in context, that we wrote a brief that was published on the website, but this was preceded by a brief that was done by the broader group that was published in BMJ Open, and they called what, well, I think in Lancet, and they called it a Global Alliance GACD Researchers Statement on Multimorbidity that really talked about the rationale for why we needed this, and Jan outlined that, and they gave 3 objectives, which I'll go into just now. And then they actually followed up with that and actually reviewed and made some suggestions for multimorbidity indicators, which Jan also referred to. And Jan's work builds on trying to systematize that. So in this brief, then, we felt that we wanted to build on the original statement and to focus our attention in on 2 target groups. One is funders, and the other one is sort of policymakers. And so the brief, really, the objective was to just sort of emphasize and highlight the importance of multimorbidity to funders and decision makers in LMIC countries. And it argues to really to stimulate research in service and service delivery in multimorbidity, and to change dominant funding models to promote that kind of research. And so as we were writing this, some of the group said, well, but we need something that our actual, heads of government can actually use ourselves. So we said, okay, we'll do a couple of statements, and then the rest of the document we'll leave open for countries to adapt themselves and to, take it to their decision makers and say, okay, how can we use this principle? So really, it's a very short statement, and it's really got the main objective is to talk about the multimorbidity area needing more attention, more evidence, and more funding. And so on the next slide, there are really two areas where we're saying that, you know, the rationale is that the disease burden of multimorbidity in LMICs is growing, and it's not well understood because it's under research, and also because the profile of multimorbidities in developing countries seems to be slightly different, with younger age groups, more complex disease interactions, etc. And so, that the second element was that multimorbidity was also worsening health outcomes and increasing costs, some of the issues that Jan spoke about. So we then said, well, we lack evidence specifically and knowledge and need research to understand the size of the problem, the causal factors, the interactions of multimorbidity. And that we also need to understand, you know, what kind of, what is the evidence base for strategies to address multimorbidity, both in terms of prevention and treatment. And then the next slide. So we really then just said, look, what is it that we can actually recommend? You know, yes, there are gaps in evidence. Yes, we need more information, but there is a lot we know already. Things that work for programs that we are involved in, and things that generally work for recommending for general increase in access to healthcare, increase in strengthening health systems. And that we need to focus on what it is we can do more immediately. So a couple of areas that I'll just quickly go over. And just to say that I think the original statement by the group that was published identified 3 areas. And this is what these points speak to. The first area is really to have increased policy awareness of the need for multimorbidity. And also to, one moment, yeah. And for that awareness to include proactive integration of chronic care systems, both for prevention, promotion, and long-term care. The second objective of that brief was to say that we need to focus research and funding to promote collaborative research across disease areas, with holistic care processes and outcome measures. And the third objective that they stated was that they wanted to promote health systems research to support universal health care, and particularly primary health care as an appropriate access vehicle for effective and efficient integrated care. So really our points just took that and unpacked it a little bit and said that we needed clinical skills, capacity building, you know, integrated guidance tools. We need health service reorganization to prevent comprehensive integrated care. We need to strengthen health system support functions. So for instance, cross-cutting functions like transport, pharmacy, drug supply, health information systems, governance and leadership, etc. And that multi-sectoral collaboration is required not just within sectors of health, but within government services. And with NGOs to address social determinants of disease. And the next slide. As well as adapting and promoting stakeholder engagement to actually shape these health systems approaches. So in particular, patients, caregivers, staff. This is often a group that is really under consulted, and I was very pleased to see in Jan's Delphi that this group is also included. Then we need, as I've said, to strengthen routine health information systems, because this is a critical area, because if you're wanting to work together as a team, even on the very frontline level, sharing of information between disease programs is critical. We want to develop and implement a whole health approach to policy development that promotes health and well-being across societal areas. So not just health treatment, but nutrition, education, employment, safety, security, the kind of social determinants of health that is actually driving a lot of these multimorbidity burden. And then the final slide is just to just to ask if there are any questions or queries, or to open up the floor.
Thanks very much. Let us say that it's now open if there are any questions or comments on multimorbidity policy brief that we have, or actually any comments on multimorbidity as a potential topic. No questions. I think it may be really helpful to have such a tool. One of the reasons it's there is for researchers, investigators, those based in whichever country, to actually use this as a background to start those conversations around, as you say, the importance of multimorbidity if it has not yet been recognized. There are often many siloed systems for delivering healthcare along a particular individual disease, and actually more and more we need to adapt and look at a more holistic approach, I think, is perhaps what we're thinking is the need in future.
Yeah, and just to say that I think that when people ask about, how to address this problem, people are addressing it from different angles. I mean, there's a whole body of literature and practice around integrated healthcare, particularly primary healthcare, and then there's a whole body of literature around interprofessional collaboration. And the whole body of literature around promoting universal health coverage. So I think when we think about multimorbidity, we need to think about fitting it within those movements of practice and of research, because it's to do with making systems work better, to deliver better for what the needs are. And, so for instance, with multimorbidity, it's not just getting integrated guidelines, but also integrated health systems to provide integrated service. Retraining so that generalist health skills become as valued as specialists. Intercollaboration between different levels, primary healthcare and specialized levels, as well as NGOs. So integration needs to be thought of in a much broader way if we are to tackle the issue of holistic multimorbidity treatment.
Yeah, really good points. Okay, thanks again. Continue to put any comments, chat, questions, queries into the chat line. Hopefully you have found it by now. There's a few links, etc., going on in the chat box. And I am going to move swiftly to perhaps one of our final items on the agenda, which is actually to share the really exciting news of our new GACD e-hub, which is an implementation science online training platform. I have a lot of preamble, but actually to cut to the basics, GACD has for many years provided in real life events, training events, both in terms of workshops and implementation science schools, very much hosted and supported through the faculty within the GACD research network. But these have always had a relative restriction around the numbers of people that can attend and accommodate, particularly restrictive when we're thinking about the participation by early career researchers in low and middle income countries. So we had been working to persuade our funding agencies to provide investment for the development of an online platform, and so that we might, for one thing, extend our reach. And this came at a very timely point when, of course, COVID actually has meant that almost everything has gone online and virtual, but allows us to maintain a positive push to capacity develop in terms of capacity strength and in terms of implementation science globally. So next slide, please. I'm going to do a quick rattle through. So the development of the eHub has been progressed by a team based in Melbourne, led by Brian Oldenburg, who I'm sure you're all very familiar with. Next slide, please. The core structure of the eHub is to provide a central training program, capitalizing on the modules and lectures that have been used previously within our implementation science schools and workshops, to combine that with some very relevant case studies to demonstrate and show practically how you would use implementation research science, and to integrate that with a hub of resources around implementation science, all overseen by an international advisory board of experts in the field. Next slide, please. The eHub has been developed, and indeed it was piloted at our implementation science school in 2020, which was a virtual event. It has subsequently been polished up a bit more, it has to be said, with many more resources added, and it went live to the public in March 2021, and it will continue to develop over the course of the next few years. Next slide, please. Just to rattle through perhaps some of the three key aspects. I'm not switching us through to a live show of how it works. I've got a few slides here that are probably quicker to rattle through. So you will use the link as in this slide. You'll land on a initial page. Next slide, please. You'll come to, on that page, or at the top of the menu, you will find the three key central elements of the online platform. And if we go firstly, if we were virtually to push the training program, next slide, please. You will come to a series of recorded lectures. You can choose to start anywhere within that series of recordings, but of course they have been set out which in a sort of comprehensive fashion that take you through the early initiation, what is implementation research, all the way through to some more complex areas. These lectures have been prepared by various experts around the world, and between the lectures you will find interactive quizzes which are quite fun, and you take the challenge to see if you've actually gained any knowledge from listening to the lectures. There's about 40 hours of content here, so it's quite an intensive amount of focus that you can apply, but of course you can come back and come back and come back. You don't have to do everything in the one go. Next slide, please. A further element is, as I've said, the resources which we have been adding to over time. Clearly, there's a lot more we can add. Very helpfully, these are external resources which provide additional information around implementation science and indeed link you to external toolkits in implementation science, lists of models and theories, etc. They're grouped currently under 4 key headings: know more about implementation science, around cancer, around stakeholder engagement and community participation, as well as around grantsmanship, which are all areas which we know that early career scientists are really quite keen to learn more about. Next slide, please. And finally, there are a suite of case studies which are very interesting, illustrate various aspects of the implementation science research that can be undertaken. Rushing through this, can I have the next slide, please? Clearly, this is a hub under development. We anticipate development in all aspects. And we are thinking about expanding the range and number of case studies, looking at the various diseases, looking in various regions. If anyone has a particular thought about new lectures, etc., that can be prepared, we can offer you the tools, etc., to prepare those such that they can be added to the toolkit. And if anyone knows of any excellent resources that we haven't already captured, we would really like to know about them. Next slide, please. The development of the eHub is overseen by an international advisory board. Next slide, please. And I think that's where I stop and say, I just encourage you to have a look at this and to share it and cascade it really widely. This is a free resource. It's open to all. You can come, you can take away some of the tools and techniques and resources that are here. Just please let everyone know where you've actually, sorry, I've got some background noise going on here. Let everyone know where you actually derived the information. The toolkit is set up under a Creative Commons license. And at the moment, it is all in English. I'm sure we would absolutely welcome if anyone felt that using the current lectures or actually creating your own lectures, you could do so in a different language that would be useful to others, then we would like to know about it. Whistle Stop's tour, I just would say, please go and have a look at this new resource for yourselves. And thank you for bringing that one to an end. Won't take any questions. If you've got questions about it, pop them in the chat, but actually it's easier to go and have a look and then come back to us if you do have questions or comments, or actually would like to volunteer a contribution. We'd really like to know. Thank you. So that's drawing us quickly to the close of today's webinar. I would just like to say thank you all for joining us. I'm sorry, as ever, we've had restricted time to have that sort of networking and conversation going. But what I would really like to do is, if you're willing, will you please at this point open up your camera so that we could take ourselves a screenshot, which we'll actually use to say, hey, look, we had a webinar and people actually were there. The 5 team were not speaking to themselves. I do hope you found it an interesting event. Really happy to take comments on how we might shape and work these better. We are rerunning this again tomorrow at 8 o'clock in the morning UK time. I don't think any of you would perhaps want to be at that duplicate session as well, but just to know it is there. It will be just a rerun of what you've heard today for the most part, although we may have a few different presenters presenting the same information. Any quick comments from the floor? I see. Thank you very much, Raymond. I see you've done a, yeah, thank you. It's been really great to touch base with you. These things are always a bit of a rush to try to pack in the information that you might want to know. We hope you want to know this information. And delighted to hear from you. And we will be running events throughout, potentially amongst our working groups, potentially amongst our programs. So hopefully we'll see you in one of those in future. Keep in touch. Have we taken a photograph? My team nodding, no. Yes, nodding.
We have, yes.
Thanks so much for your attention. I don't see any quick questions in the chat box. If we have, we'll try and get back to you on an individual basis, but see you again in the not too distant future, I hope. Thank you for attending. Bye.
Thanks.
Oh, it's